I became interested in disparities in health outcomes during residency at Dartmouth. I got a chance to do their public health program as well during residency, got to look up close regarding some of the public health challenges facing us right now, including disparities in health outcomes. And I want to talk to you guys this morning about health outcomes from a neurosurgical perspective. I have no disclosures. By the end of this talk, I'd like to have reviewed an introduction to health disparities, also look at some of the literature that has come out regarding healthcare disparities in neurosurgery, including some of the work we did at Dartmouth. We'll then talk about some of the potential causes of these disparities, and it will provide a segue to the social determinants of health, which are an important point of concern nowadays, as we'll see. And then we'll end this talk talking about strategies to mitigate these disparities and how far we've come and how far we need to go. So let me start off with the introduction. And we'll talk about the definitions, why it's important to discuss disparities in the first place, and then we'll move on from there. So the COVID-19 pandemic has really brought to the forefront the long existing healthcare disparities that have been present in our society. Over the last 2.5 years, this has become a topic of discussion, both in popular media and in medical literature. And I'm sure we've been exposed to these headlines in various different formats. And the reason for that is that these underlying disparities have led to unavoidable negative clinical outcomes for some groups of patients, particularly racial and ethnic minorities. As we can see in this particular graph from the CDC, patients who belong to minority groups in general get infected more frequently, get more sick, so require hospitalization more frequently, and are dying from COVID-19 more frequently than white patients are. Interestingly, for Black patients, the number of cases or the proportion of cases is about the same as white patients. But when they do get sick, they get really sick, requiring more hospitalization, and they're dying from it at a higher rate compared to some of the other groups as well. So some of the definitions, and these definitions are from the CDC. Disparities, as defined by them, are preventative differences in the burden of disease, injury, or violence, or opportunities to achieve optimal health. And these are experienced by populations that can be disadvantaged by various reasons, such as social or economic status, geographical location, or environment. And it's also good to point out what health equity is. And this is a state in which everyone has a fair and just opportunity to attain their highest level of health. So a lack of health equity thus leads to these health disparities. And health disparities may exist across various domains: racial and ethnic, gender, sexual orientation, age, disability status, socioeconomic status, and geographical location. The focus of my talk today is going to be racial and ethnic disparities because most of the work done is in this particular realm. However, there's also data, patchy somewhat, but on other aspects of domains as well and how they influence disparities. Now, healthcare disparities are not unique to the United States, but it does appear that we fare pretty bad compared to some of the other developed countries. This was a Commonwealth Fund analysis completed last year. They sent out questionnaires to patients and healthcare providers to 11 different countries from the OECD bloc to see how they did in various health metrics, including access to care, care process, efficiency in administration, equity in healthcare outcomes. And if you look at equity in healthcare outcomes, among other metrics, unfortunately, we were dead last. And so we as a healthcare system aren't doing very well. And if you add to the fact that our healthcare system is oftentimes criticized for being pretty expensive, that's also problematic because healthcare disparities cost money. This is a study by Leviste and colleagues, and they analyzed data between 2002 and 2006 using CMS Medical Expenditure Panel Survey, as well as National Vital Statistics reports. And they found for this 4-year period, direct medical care expenditures cost us $230 billion. And indirect costs associated with illness and premature death cost us up to $1 trillion for treatment of patients affected by healthcare disparities. As you can see from this graph, bulk of the cost was from disparities seen in African Americans, but also sizable contributions from groups such as Hispanic and Asians. This is a more current analysis of the cost of healthcare disparities. This is from Deloitte, published earlier this year, who looked at a particular set of disease states, such as hypertension, diabetes, chronic kidney disease, hypertension, hepatitis. And they tried to establish a baseline for the costs potentially attributed to inequities and bias. And they found that this year alone, we'll spend about $320 billion just to treat inequities. And if you were to extrapolate this data 18 years into the future, assuming that the inequities remain the same, and also factor in expected changes in population, demographics, cost of care, and per capita spending, the cost of inequities is going to balloon up to $1 trillion every year. And so this is a big point of concern for policymakers and public health experts moving forward. So let me come to some of the neurosurgical literature on healthcare disparities. And I'm going to talk about some of the major subspecialties in neurosurgery and see what they have found from their studies. We'll talk about neuro-oncology, TBI, pediatric, cerebrovascular, and of course, spine. Starting with brain tumors. This is a study by Thomas and colleagues published last year. They looked at patients who underwent brain tumor resections and interrogated the American College of Surgeons National Surgical Quality Improvement Program, analyzed a little over 12,500 patients between the years of 2006 and 2019, and focused on complication rates after surgery. And they found that in African American and Black patients, the odds of suffering adverse cardiovascular events or pulmonary events or urinary tract infections were significantly higher compared to white patients. Similar data was documented by Curry and colleagues. This is a slightly older paper. They used the nationwide inpatient sample between 1988 and 2004 for more than 99,000 patients and looked at mortality and discharge dispositions. These tables are a little busy, but 2 points I want to point out. First of all, in Black patients, there was significantly higher likelihood to die, 60% more likely. And for discharge dispositions, there was a significantly higher odds of discharge other than home in Black patients, up to 40% higher likelihood. This is a study by Nuno and colleagues, and they also used the nationwide inpatient sample. They focused on craniotomy for brain metastases, and they stratified their outcome measures not only based upon race, but also gender. And they found that for Black females, mortality and non-routine discharge was significantly higher compared to their white counterparts. For Black males, on the other hand, there was no significant difference in the mortality rates, although non-routine discharge was also significantly more common. So it does appear that these patients are not doing very well as an inpatient after brain surgery. There's also longer-term data on patients with brain tumors. This study by Hodges et al. Interrogated the National Cancer Database, evaluated more than 100,000 patients, and looked at 30-day readmission rates, and found that for Black non-Hispanic patients, the odds were 40% higher of them having to be readmitted after their index admission. Data in the TBI realm is similar. This is a study that was published last year from OHSU, where they looked at their data set for trauma between 2006 and 2017 for a total of 6,352 patients, and they used propensity score modeling to balance out their covariates. And looking at survival in particular, they found that patients belonging to minority ethnic and racial groups had significantly lower survival compared to the majority groups. The red line signifies the majority, the blue line, the minority groups. These curves are for unadjusted analysis, and when they did adjust the analysis, the difference remained essentially the same. Patients belonging to racial and ethnic minorities were doing worse after TBIs in their data set. We have data from bigger data sets as well. This is a study from Meager and colleagues that look at discharge to rehabilitation using the National Trauma Data Bank for the years 2007 to 2010. And they evaluated a little over 299,000 patients with TBI incidents. They also used propensity-weighted analysis to balance their covariates. And they found that in Hispanic and Black patients, the odds of being discharged to rehab was significantly lower compared to White patients. Similar results was quoted by Simora and colleagues, who used a nationwide inpatient sample for a large data set and showed that even in spite of being insured, Black patients, Hispanic patients, and Asian Pacific Islander patients had a significantly lower incidence of being discharged to rehab after their TBI compared to insured White patients. Let's move on to the pediatric side. This is a study that was done from the Texas Cancer Center Registry between 1995 and 2009, focusing on children with CNS solid tumors. They evaluated data on 2,421 patients, and they found that survival was much worse in Hispanic and non-Hispanic Black patients. The bottom two lines in the Kaplan-Meier curves belong to Hispanic and Black non-Hispanic patients. The top two lines belong to the other groups. Similar results were quoted as well after assessing the SEER data set. This looks at patients with central nervous system tumors and brain tumors in the United States. They analyzed a little over 8,700 patients, and again found that minority racial groups had significantly higher hazard of death after treatment for these conditions compared to White patients. And again, the graph, the bottom lines are Hispanic and non-Hispanic patients. The top line is for the majority White patients. People have also looked at other conditions in the pediatric population as far as racial disparities are concerned. This particular study looked at the racial disparities after undergoing shunt procedure for cerebrovascular, cerebrospinal, pathologies. They used the kids inpatient database, which is similar to the nationwide inpatient sample, but for children. And they analyzed more than 37,000 hydrocephalus-related shunting procedures and found that as far as the odds of inpatient death are concerned, African-American patient had a 50% more likelihood of dying after procedures, and Asian Pacific Islanders were more than twice more likely to have died after a shunting procedure. They also looked at non-routine discharge and found that African-American patients and Asian Pacific Islander patients were also more significantly likely to be discharged to a place other than home, showing again that these patients in general are not doing as well as some of the other groups. There is a lot of literature in cerebrovascular side as well. I'm just going to talk about one quick review that was published just a couple of months ago. This systematic review analyzed 46 retrospective reviews and one prospective observational cohort study, including procedures in cerebrovascular, including carotid artery stenting, carotid endarterectomy, mechanical thrombectomy, and endovascular aneurysm coiling or surgical aneurysm clipping. And their conclusions included that minority and underinsured patients were less likely to receive surgical treatment, and that when they did get treatment, they were more likely to experience a post-operative complication. And similar to the data that we've just discussed in other subspecialties, White and privately insured patients had shorter length of hospital stay, had lower rates of in-hospital mortality, and at significantly higher rates of routine discharge. Moving to spinal cord injury, and we have some good data in this particular side as well. This study by Ladd et al. Looked at the National Trauma Data Bank from 2000 to 2009, analyzed more than 18,000 patients, and looked at death, complication rates, and discharge disposition in these patients, and found that while mortality rates after spinal cord injuries did not differ between Black, Hispanic, Asian, and white patients, the rate of complications after a spinal cord injury was significantly high in Black patients. And when it came to discharge to rehab, all racial minorities were less likely to be discharged to rehab compared to white majority patients. There's long-term analysis as well for these patients with spinal cord injury. This is a study from the 2011 National Spinal Cord Injury Models database. They included over 5,000 patients, and they particularly looked at the rate of hospitalization after their spinal cord injury at year 1, year 5, and year 10, trying to see how patients were doing long-term after their particular injury. And they found that compared to white and Hispanic patients, African-American patients at all these time points were experiencing higher rate of hospitalizations, somehow showing that these patients were not doing as well, suffering more complications and medical issues. We also have long-term employment outcomes in these particular patient subset as well. This particular study looked at employment between whites, Hispanics, and African Americans at year 1, year 5, and year 10. And the first column compares whites versus Hispanic patients. If a confidence interval crosses 1, there's no difference. But as you can see, white patients are significantly more likely to be comparatively employed versus Hispanics at all of these time points. The second column is white patients versus African-American patients. Similar results, you see that white patients are significantly more likely to be employed at year 1, year 5, and year 10. This difference seems to be increasing as time progressed. And they also compared Hispanics versus African-Americans and found that there was no big difference in the first 2 time points, year 1 and year 5. But by year 10, Hispanic patients were still doing a little better. African-American patients still had the lowest rates of being comparatively employed. And so this brings me to some of the work that we did at Dartmouth. I'm going to share a meta-analysis and a systematic review that we conducted on the racial disparities in outcomes after spine surgery. We focused on degenerative spine conditions. This is our flowchart showing that we initially were looking at a little over 500 studies, and we wanted to focus on studies that had documented outcomes after spine surgery, but they had also stratified it according to racial groups, so we could analyze it in our meta-analysis. And we kind of whittled down to 30 articles that we were able to include in our review. Of these, we could only use 20 cohort studies for our meta-analysis because they had the data we needed to conduct our calculations. But some of the things that we looked at included the risk of mortality after spine surgery. This analysis pooled 8 studies together and found that Black patients had a 55% higher likelihood of dying after spine surgery compared to white patients. Similarly, we looked at length of stay after spine surgery for degenerative pathologies and found that the length of stay was significantly longer for Black patients compared to white patients. We also looked at the risk of major complications after spine surgery. And similarly, we did find that Black patients were more likely to have complications after spine surgery, to 20% more risk. But this particular difference did not reach statistical significance in our analysis. And looking at the risk of non-home discharge, echoing the findings of what we've seen in the previous studies, there was a significantly higher risk of Black patients being discharged to places other than home after spine surgery compared to white patients. We pooled 6 studies for this particular analysis. A couple of things I want to point out about this particular meta-analysis before we move forward. First of all, it's important to know that there was a big heterogeneity in the results in all of our analysis, predominantly because we were trying to pool together different surgeries at different particular locations in the spine. And so that did lead to some heterogeneity. Also, because of the way the data was presented in the papers that we analyzed, this is not a meta-regression, which is to say that we have not adjusted these or could not adjust these for different confounders. But we did note that the original studies from where we got this data from, almost all of them had adjusted results looking at racial outcomes and had found that racial ethnic minorities, particularly African American and Black patients, were doing much worse. And the last thing I'd like to point out about this meta-analysis is that even though we included more than 3 million different surgeries in this analysis, and we looked at the racial makeup of our cohort, only 7% of all the patients were African American in our entire cohort. And if you know, in our national demographics, African Americans are 13% of the population. And so this brings into question why we are seeing less data from African American patients. And there's no real data to suggest that the incidence of spinal pathology is lower in ethnic minority patients. But what might be an issue here may be access to care. So let me move on to potential causes of healthcare disparities. And I will go over some of the neurosurgical literature that have tried to elucidate some aspects of these causes. And I'll start off with access to care, because this seems to be one of the biggest concerns that we have with regards to providing timely and effective care to racial minorities. And this is a paper by Pira and colleagues earlier this year. And they tried to assess the distribution of the neurosurgical workforce around the country to see if there was any social determinants of health that were associated with unequal access to neurosurgical care. And interestingly, they found that in catchment areas with higher proportions of Black residents and higher poverty were associated with greater neurosurgeon density. On the other hand, they found that in catchment areas with Hispanic populations or with Native American populations had a significantly lower neurosurgeon density. So overall, from that perspective, it appears that as far as our workforce distribution is concerned, neurosurgeons are at least doing a decent job of being in places where they may be needed the most. But as we know, distance to physician is just one of the factors to access to care. The issue with access to care is much more complicated. And there are many more factors that go into making sure the patient gets to the doctor they need to see. For example, referral patterns play a big role. This particular study kind of highlights that. This is a study done by the Henry Ford Medical Group, and they looked at patients with trigeminal neuralgia that presented to their healthcare system between 2006 and 2012 for a little over 652 patients. And they found that Black patients were less likely to undergo percutaneous ablative procedures, stereotactic radiosurgery, or microvascular decompression compared to white patients. And more importantly, they found that once these patients saw a neurosurgeon, there was really no difference in the likelihood of undergoing a procedure. The difference was 67 versus 70%. And according to their discussion, they thought the problem was more upstream in how the patients were referred to neurosurgeons, and that they were not getting to doctors in time or at all to get the treatment that they may need. We know that there are conditions where delay of care can be a great issue. This is a study that looked at degenerative cervical myelopathy. The investigators in this particular study conducted an online survey on myelopathy.org, including 778 patients, to figure out what the delay was between them having started to have symptoms and them getting diagnosed with cervical myelopathy. And they found that the average delay in most patients was between 1 and 2 years. And they also found that the greater the delay, the greater the disability, which is not surprising. We know that when patients present later on in the course of their disease, particularly with cervical myelopathy, they don't do as well as if they presented earlier. But when they stratified their results based upon racial groups, that is when they found something concerning. They found that Black or African-American patients were waiting way too long to be diagnosed with cervical myelopathy. Half of the patients were waiting more than 2 years before they were diagnosed with cervical myelopathy. And over a quarter of the patients were waiting more than 5 years before they were diagnosed with cervical myelopathy. And so it's not a surprise that a lot of these patients would not do well because they've been suffering from these symptoms for such a long time, causing irreversible damage. There are other conditions as well. Neuro-oncology is a great example where delay in treatment can affect outcomes in a big way. This particular study from the National Cancer Database looked at people more than 40 years of age with glioblastoma who had underwent craniotomy, evaluated a little over 68,000 patients. And they looked at, first of all, radiation therapy after craniotomy for a glioblastoma, and found that while there was no difference between Hispanic and Black patients and Asian Pacific Islander patients, Hispanic and Black patients were getting radiation that was started much later than white patients. Similarly, they looked at chemotherapy, and they found that the results were even more stark here. Hispanic and Black non-Hispanic patients had a significantly lower likelihood of receiving chemotherapy in the first place. And when they did receive chemotherapy, it was initiated days later compared to white patients. And so, again, harking back to the results showed earlier today regarding survival, it's no surprise that these patients may not do as well with long-term outcomes. It's also important at this point to talk about some of the cultural differences. I apologize. For right now, we'll talk about the surgical volumes and how they are positively associated with health outcomes. So this particular study by Schoenfeld looked at the Florida inpatient data set to see how and where the patients were getting their surgeries from. And we know the surgical volumes are positively associated with health outcomes, which is another way of saying, if you get your surgery from a higher volume surgeon or at a higher volume hospital, you generally tend to do better compared to the opposite. And they found that for African-American and Hispanic patients receiving spine surgery, they were more likely to have gotten it from a low volume surgeon at a low volume hospital. And then coming to some of the cultural preferences of patients undergoing treatment, it's also important to see because there might be some diversity in opinion there as well. For example, this is analysis by Arrigo and colleagues that analyzed baseline data for patients who were enrolled in the SPORT trial. The SPORT trial was one of the largest spine randomized blinded controlled trial completed in the early 2000s that compared operative versus non-operative treatment for conditions such as disc herniation, spinal stenosis, and degenerative spondylolisthesis. These investigators wanted to see how or what the preferences with treatment were for the patients that were initially enrolled in the SPORT trial. And they found that Black patients were less likely to prefer surgical treatment compared to other groups of patients. And this was true for all pathologies that they studied: disc herniation, spinal stenosis, and degenerative spondylolisthesis, pointing out that there are some cultural differences between different groups as far as their preferences with treatment is concerned. And this brings me to discussing the social determinants of health, because all of this data suggests that there are major social determinants that are driving forces behind the healthcare disparities that we observe today. And these include, but are not limited to, social norms and attitudes and economic stability. And while we are often incapable of, as healthcare providers, of addressing these aspects of health determinants that are so far upstream from healthcare, we are oftentimes tasked with managing and attempting to mitigate the consequences. So it's important to know about these. This particular diagram is from the CDC's Healthy People 2030 initiative. And the CDC has made understanding social determinants of health and addressing them a big part of their push moving forward. This figure shows us the 5 major categories that are included in this particular cohort. It includes education, access and quality, economic stability, social and community context, neighborhood and built environment, and healthcare access and quality. And it's important to know that concepts such as implicit bias and systemic racism pervade all of these categories. And there's also some data that estimate, at least at the public health or population health level, that clinical care impacts only about 20% of county level variation in health outcomes, while social determinants of health may affect as much as 50% of the variation in health outcomes. So it is a big issue that we need to study. And there is some neurosurgical literature that has tried to study this in a systematic fashion. This is a study by Halder et al., a group at UPenn, that looked at their center, analyzed retrospectively 567 consecutive pituitary tumor cases over a 6-year period. And what they tried to do was they tried to adjust for social determinants of health in their analysis to see if the difference in outcomes between different racial groups may be attenuated, thereby showing that it was the social determinants of health that were driving these disparities. They used a matching criteria to help them with their analysis. They matched them for various different confounders, including some social determinants of health confounders. The biggest issue with their particular analysis is the fact that they started off with 567 patients, but when they completed their matching, they were left with only 92 patients. And so there was a bit of a sampling bias there. But what they did find was, for most of the metrics that they studied, including a 30-day return to the OR, or 30-day readmission rate, or 30-day return to surgery after they got discharged, there was no difference between the different racial groups. Although 30-day ER evaluation was a little higher in Black patients. But again, important to note how wide their confidence intervals are because of their small sample sizes. So there's a lot of uncertainty. But this does bring us to an issue that it is difficult to analyze the exact effects of social determinants of health on health outcomes because we are not doing a very good job at capturing them in our data set in the first place. And part of the problem is our coding. For a long period of time, we did not have adequate social determinants of health codes that we could capture data from. This was recognized by the ICD-10 folks, and they came up with an expanded category, the Z categories, for social determinants of health codes to be able to document and capture this information more completely. The idea behind this, according to the CMS, is that we need to collect data in a more systematic fashion. So we may be able to then analyze it and see how we are doing and figure out how much of these determinants have an influence on healthcare outcomes. To make it easier for us to be able to capture these, they may be captured by any member of the care team. So it doesn't have to be a physician or physician assistant, but it can be a nurse or a social worker or a case manager that is involved in the care of the patients. But also importantly, as of right now, these codes are not reimbursable. And so there is a concern that compliance will probably be a little patchy. Saying that, we do need some data showing that these social determinants of health have real life consequences in our patients' outcomes. So then we may push CMS and different agencies so we may get reimbursed for this particular condition so we can pay more attention to them. So let me move on to some possible solutions to mitigate these disparities. And some of these are generic points that we are already doing and paying more and more attention to as time moves forward. But it's very important to deliver patient-centered care, something that we aim to do as a field. There's data suggesting that using patient decision aids and educating patients regarding options and their pathology can help improve decision-making, compliance after treatment, and eventually healthcare outcomes. It is important to continue to raise public and provider awareness of racial and ethnic disparities in care. It's also important to promote a diverse healthcare workforce because we as a healthcare treat patients who belong to diverse backgrounds. This is something that I know neurosurgery is doing as a priority as well. And then talking about data collection is very important to maintain accurate and complete racial, ethnic, and social determinants of health data, so we may be able to analyze and monitor disparities of care. Furthermore, it's also important to set measurable goals for improving quality of care and to ensure that these goals are achieved equitably for all racial and ethnic groups. And these include our QI projects. We need to make sure that that any quality improvement is experienced by all patient cohorts. We also need to leverage technology to increase healthcare access. And this includes telemedicine, which played a big role in reaching out to patients during the COVID-19 pandemic. But we can also get creative, for example, and use smartphone apps to get access. And a quick shout out to Dr. Hofstadter's initiative in using a smartphone app to follow up patients who underwent spine surgery. And these all little things help increase access. It's also important to expand healthcare insurance coverage to increase access. We have data to suggest that in states that opted in for Medicaid expansion did well as far as access to care is concerned. And then we also need to conduct local community health needs assessments to identify areas for improvement. An example for this is the recent King County Community Health Needs Assessment. This was published earlier this year. This assessment was conducted by 10 different hospitals, included University of Washington as well. And they looked at various different markers of health in the communities around this area. There was multiple things they documented on. This is a very interesting report if anyone's interested, but they found, for example, obesity rates was stable in the King County area. Cigarette smoking was going down compared to the last report in 2018, 2019. But while cigarette smoking was down, vaping was up. Homelessness had declined since the last report was published, although youth obesity was increasing. And they also make a note of racial disparities in life expectancy. Because the COVID-19 pandemic, life expectancy went down for all groups, but it went down more so for minorities. And it's also important to note that even though a lot of these interventions are important, they are mostly centered around the healthcare system. And if you look at the social determinants of health ecosystem, you notice that most of the determinants are actually upstream. For example, while it is important to address the individual's healthcare needs, we also need to pay attention to individual social needs and also to address some of the structural issues present within the communities before we can mitigate any disparities that we see. And this brings us to the government and different agencies responsible for health policy. This figure gives a timeline for some of the landmark actions by the US Supreme Court, the Congress, and the presidency in trying to improve healthcare access, improve health equity, and shape the unique healthcare environment that is the United States. Most of these have been positive steps in the right direction. This paper was published before the Roe v. Wade decision from the Supreme Court, but we have made progress over the past couple of decades. Important to note that last year, the Biden administration came up with an executive order to combat racism and inequities in healthcare. So this is an area of great focus for different federal agencies. And this is from a report that was published by the US Department of Health and Human Services. And they're trying to devise a strategic approach to addressing social determinants of health. And they looked at all the interventions done around the country that have yielded positive influence on the health of different patients. For example, they looked at housing first interventions that provided supportive housing to individuals with chronic health conditions and found that this led to improved compliance with healthcare as well as improved outcomes. They also found that evidence-based nutrition standards help decrease the burden of disease in patients. Availability of non-emergency medical transportation can help increase the use of preventative and outpatient care. And help decrease costs associated with emergency care because you're preventing a lot of the problems. There's also data to suggest that cash payments to families and income support for low-income individuals with disabilities can help improve their outcomes. There's also data that shows that the child tax credit that was handed out last year for low-income families with children helped decrease the rate of child poverty. We haven't drawn the line from there to improved healthcare outcomes, but certainly an important point moving forward. And then, of course, care management and coordination using multidisciplinary teams can help coordinate care and improve outcomes in these patients. And again, make it such that patients are being seen by healthcare providers that need to see them in a timely fashion. So in conclusion, healthcare disparities in outcomes are a pervasive problem in healthcare, and that includes neurosurgery. The causes of these disparities are complex, and they're interlinked, and they're multifaceted. Understanding the social determinants of health can help increase understanding of the underlying barriers to achieving health equity, and interventions that address both the upstream and downstream determinants of health can help mitigate the observed health outcome disparities. A quick word of acknowledgement to the leadership of the program, Dr. Ellenbogen, Dr. Hofstadter, Dr. Zhang. Thank you for the opportunity of bringing me here to train. Shout out to the Dartmouth faculty, neurosurgery faculty, as well as the faculty at the Dartmouth Institute, their public health school. These are my references. I thank you all for your attention. Just a reminder of a lovely summer that we've had in the Puget Sound region, especially now that the sun has decided to take a break. Thank you for your time.